So let's look at some pigmented retinal lesions. Choroidal nevus is something we all see commonly in every practice. And the important thing here is to remember it's a choroidal nevus. So we're looking at RPE, but we're not going to look anteriorly. We're actually going to look posteriorly because that's where you're going to see the nevus. You don't really see too much because all that pigment is going to absorb your retinal signal and it just ends up being like a shadow. Again, that shadowing effect is going to be there because of the pigmentation, but overlying that shadow, you can see there's going to be some choroidal thinning, which happens very, very often with choroidal nevi. Now, as opposed to melanomas, which tend to be very elevated, here the retina is basically intact. Chirpy is something that I think we should understand more on a cellular level. So the normal RPE is going to be one layer of RPE cells. Hyperplasia is when you're going to have more cells. Hypertrophy is when the cells are larger, but there's the same amount of them. And then in a chirpy, it's when you have those hypertrophic cells, but they actually have more pigment in them, which is why they seem so dark on fundoscopy. Now, this is a case from Jerry Sherman, who is one of my mentors. So thank you for the case, and I have to give him a quick shout out for that one. Looking at the RPE, you see that it's thickened, and there's really nothing posterior to it, unlike in that choroidal nevus. But if you look anteriorly, you will see that outer retina is really deteriorated, and in fact, the inner retina starts collapsing down. This is happening because the outer retina is going to atrophy away because the chirpy can't sort of nourish or accommodate that outer retina. Looking at a chorioretinal scar, these are very often due to inflammation, which is a very irregular reaction within the retina. And this will very often atrophy the retina to a significant extent, so you get almost no retina overlying that pigment hyperplasia. And you can see that the RPE is very irregular. And then there are these little retinal cysts just because the retina is being pulled down because there's nothing to support it. So looking at all three of these back to back, even though on fundoscopy they might look similar, on OCT you can always tell the difference between all three. So looking at AMD, we all have these patients, and drusen is an interesting term because we call a lot of things drusen, but we can actually subdivide them a little bit.